Welcome to the SIWIKE podcast, the only podcast that shares the stuff you didn't know you needed to know about jobs, careers, and life. The SIWIKE podcast, the stuff I wish I knew earlier.
Hi, everyone, and welcome to the SIWIKE Stuff I Wish I Knew Earlier podcast. We're here again with our guest host, Eram, who is our trauma ER nurse. And we wanted to have a little bit of a conversation in terms of, do your parents and friends really know what you do, right? So you're a nurse, which seems self-explanatory, but is it, I guess? Do folks actually know what you do? And when you tell them, like, well, they see what's on TV, they see what's, I guess, in the media, what's in, like, the storybooks as a kid, you kind of have those community helpers, and they talk about that. But what do folks think that you do, and what do you actually do?
Thanks so much for having me back on. So no, people don't really know what we do. I really think that the only way that you'll know what we really do is if you actually speak to someone that works in emergency trauma services. Mm-hmm. And of course, nursing has different branches. So you don't really know what a nurse really does until you speak to each one of them. So you speak to someone like myself, I could tell you what a day in the life of an ER trauma nurse is. You speak to another nurse who, works with medicinal marijuana. He or she will tell you something differently, and so on and so forth. So when you have these books that are like storybooks about, what we do, I don't think they entirely capture everything unless it's written by someone who is a healthcare professional that works in that field. In terms of movies and shows like House and so forth, those are a fantasia of what we really encounter in the ER or in a trauma center. So the only way that you'll really know is when you speak to somebody.
And you mentioned, or off the air, you were discussing about someone that does actually get you, because you mentioned your mother, and tell us a little bit more about, like, why does your mother understand it and get what you do?
Well, first off, I think it's because I'm very close with my mother, mm-hmm. and she's seen a lot of things that I've been through personally, but she's also, like, quite aware of how in terms of what I've seen while mm-hmm. working. So, if I came home and I wanted to de-stress and I wanted to vent, talking to her, she would understand what I've been through, or just even seeing, and truthfully, after a shift, you can get exhausted, you can get tired. I mean, you have good days, but most of the days are really crazy when I work. Right. So, she fully understands it. But I think it's also because in the past, unfortunately, she has had to be a patient herself in the ER. Okay. And so she has seen the way an ER runs, and she's seen the way that nurses run to do their work, and working in teams with physicians and other healthcare professionals. So she's kind of seen that as a firsthand experience as well.
Yeah, so we've talked a little bit about kind of the nursing myths and misconceptions in our Nursing Demystified episode. But wondering if you could share a couple of those stories, right? Obviously anonymized, so that you're not naming names or any specific details, but in kind of a generality. So maybe one of those days when you were kind of running around and like just had to deal with things coming left, right, and center, and kind of hot heavy as they get into the ER. But can you give us a story about, like, what that might be indicative of what does an ER trauma nurse actually do?
Well, I mean, the thing is that things can be quiet one moment, and the next moment you have something and you have absolutely no idea about. Nothing is textbook perfect coming in through that door. But of course, you have to put on your critical thinking cap. You have to be really in that mode, and you have to have all distractions out and really, really think, because you have to be quick on your feet and you got to really move. So I can give you one example. So I had an assignment of patients with my partner, and our patients were stable. all of my patients were post-trauma. So basically my goal was pain management for all of them. So, I had gone in, all of them seemed pretty comfy, cozy and everything. And then in the same zone, which is the area where I was working in, I had a partner of mine, not the same nursing partner that I had, but it was, another nursing colleague that was working in the same zone who was running up a bit busy. I said, you look a little busy. Do you need any help? So that's kind of like the thing that you do. If someone's busy, they look like they're heavily occupied, they need some help, you go with courtesy to go and assist them.
Sure.
So, he said, yeah, actually, I really would appreciate if you could help me, if you could give some pain medication to my patient right over there. And I said, sure, absolutely. Can I just see the chart? So I review the chart quickly and, I look through it and then I see the orders and I say, okay. So I go over and this is a young woman who's probably in her early 40s, late 30s, early 40s. And this is pre-COVID time. So her husband was sitting in a chair. He looked pretty irritable and she just was in pain. So I introduced myself and I offered her pain medication and she said, yes, I would like some pain medication. So I constituted up the pain medication and I pushed a very small amount, obviously within limits. And of course, as per protocols by the hospital. And it was a very, very small amount. And so I just decided to take her vitals, have a look at her pressure and see, what's going on with her. She obviously had an IV line in and she had fluids running in. So her pressure was on the low side. So I thought, well, wait a minute, that can't be right. Like, that much pain medication can't really tank a pressure that fast.
Sure.
So I had a closer look at her and she was lying in a stretcher. So I went up to my nursing colleague and I said, well, she's lying in a stretcher here. And this was actually known as an ambulatory zone, but we had graciously offered her and courteously offered her a stretcher because she had been in pain. So I said, well, why isn't she in a room? Like, why was she not triaged in a room? So the only information that I got was that this lady has a history of endometriosis and was a bounce back to gynecology.
Okay.
So she came in because she was having uterine pain.
Okay.
And she just wasn't feeling well. So I said, okay. I said, fine. Well, I said, but she just doesn't look right. I just had a gut hunch. I said, she doesn't look too right. So he came over and I just looked at her. I just had a look at her and she looked rather jaundiced, like very yellow in color. And I said, she doesn't have jaundice, does she? And he's like, no. And I just looked at her. Like, I mean, it's quite a question to ask because she's referred to gynecology, but it's still like, you look really yellow.
Yeah.
So I just said, you know what? I said, can you do me a favor? Can you page gynecology and get me a line? I'm going to start another line and start her on some more fluids. And I said, her pressure's low. This isn't right. So we both collectively decided to put her in a resuscitation room. So in a trauma center, any room becomes a resuscitation room, unlike a community hospital, but in community ERs as well. If you have no choice, but you have the staff with the skills and the training, you can run anything. So we push her in. So my partner and I push her in. And I told my other nursing partner, I said, listen, all my patients are stable. I'm just going to go help him out because this patient looks really unwell. So she said, yeah, don't worry about it. If there's anything, I'll take care of it. So, I walk over. So we push her over and we wheel her over into the resus room. So, she's looking really sick. And then I look at her abdomen and I'm like, that abdomen looks really distended. So when I go and I palpate her abdomen, it's like rock hard. It's like rock solid hard. So then I said, okay, well, I just have to ask this. This might be ridiculous, but is she pregnant? And he says, no. Okay. So the husband is, getting a little agitated. So, I gave him a chair to sit outside and, I offered him something to drink just to keep him, calm because I think he was more worried about his wife, to be quite honest with you, right. which is legitimate. And I can understand that. So I told my partner, go get the emergency physician because it looks like gynecology is not coming anytime soon. I hook her up to her monitor. Her blood pressure is somewhat improving, but she's still very soft. And when I say soft, her pressure is low.
Right.
So there's a ton of things that are running in my mind. I start a bunch of lines on her and she's not perfusing well. So that's another problem. And her heart rate's going up. And I'm thinking, okay, what's going on here? She came in as a walk-in and all of a sudden her pressure's starting to tank. This is ridiculous. Like something's not quite right. So now we have to start IVs like crazy on her. So at this point, I think I've put in 6 IVs in her to get access, including her foot. Including her foot. So I'm just like, oh my God, there's something not quite right here. So the ER doctor comes in and we give him a quick history. He's like, okay, that's fine. And my partner is now looking a little pale himself. And he's like, I'm getting really worried. And he goes, I'm getting scared. I think I'm going to faint. I said, you're not going to faint. Here's some apple juice. Stand in the corner and chart. I'm going to take over now. So I tell him, like, go by the computer, print labels and chart and drink this apple juice. Because there's no way, son, that I'm going to have 2 patients in one room. Okay. So we're going to make this happen. So now I have pager phones. So these are the pager phones that we have if we need to like contact diagnostic imaging or, just to call anywhere and et cetera, et cetera. So the triage nurse is running in. She goes, what happened? I said, well, you triaged this person into a chair zone, which is now into a resuscitative bed. And she felt really awful. Okay. But I mean, things can change, which I understand. But I mean, sometimes you have to be a little more cognizant on things. So anyways. Sure. So now the ER doctor's like, okay, so we need to stop. We need to start fluids, which we've already started. We're pressure bagging in fluids like crazy. I'm paging gynecology off the hook. So here's one phone in one pocket. Here's another one. And there's another one in my back pocket. Now I have 3 pager phones. And, it's just getting insane. And then I'm like, okay, so I say, you know what, maybe we should ultrasound her belly because that looks really distended. So he does an ultrasound, he does a quick fast on her and he's like, okay, well, this is the culprit. So apparently she was bleeding out in her abdomen and we found 4 liters of blood in the abdomen. So I look at him and I said, okay, so now we're going to do a massive transfusion. So he's like, yes. So I call the blood bank and I'm like, okay, we're going to do a code omega, get like a couple of units of O-neg and send this and send that. And I'm pushing in drugs like crazy, hanging in like, drugs that are supposed to stop bleeding, and all that kind of stuff. So, we're pushing in tranexamic acid, we're doing vitamin K, we're going crazy here. She gets a Foley in, we're monitoring her pressures. So she's a sick lady. Right. And so then we get an ICU resident to come in to insert more lines, which are more advanced. So like an arterial line and a central line. So arterial line, as the name suggests, means access to the artery, which goes into, well, it could go in the femoral, but in this case, he decided to go radial. So I said, okay. And then central line. So he put one in her neck right here. And in this area right here, the jugular area. And so then he also inserted another one by the femoral area. And now we have more access more now than ever, but her blood pressure is still tanking. So now this is where we get intensive care involved. So I say, okay, well, the blood is here. We're transfusing in blood like crazy. Like this is blood that's like running on gravity, and so then I pull 2 more float nurses. So this is me organizing everything to the point the ER doctor's like, okay, you're taking control. And I'm like, you need to get a rapid infuser. I need 2 of them right now because we got to push in this blood really fast. Right. You got to infuse this blood in really fast. So the blood's going in. I'm trying to now get in touch with gynecology. They're still not here yet. Intensive care is here taking over. Blood pressure's dropping. I say, okay, well, you know what? Now I'm going to start pressure support medication. So life support medication. So she walked in and now she came in from a walk-in to now being on like life support medication. Okay, so now we have a couple of drugs. We have this going, we have that going, we've got antibiotics for, broad spectrum, just for defense. And, highly likely she's probably going to end up going to gynecology, but now going to the OR and, of course, ICU. Sure. So while all of that is happening and all of that, we have that all under control. All of a sudden, she kicked her leg in the air. So it was unusual. She kicked her leg and then she seized. She's had a seizure. I said, oh my God. So I had to push in a drug, which is basically like, like Ativan, for example, an anti-seizure medication to stop her from seizing, which happened, which she did stop seizing. But then she seemed to not be protecting her airway because she started having what's called guppy breathing or like snoring. And when she wasn't really responding to that, I literally said, that's it. I literally turned to the fellow, the ICU fellow, and I said, listen, she now needs advanced airway. She now has to go on a ventilator. She has to be intubated. So the fellow's looking at me and he's like, I don't want to intubate her. I said, you do realize that she has a compromised airway and that if you don't intubate her, she's going to arrest. Right. And she's in her 40s and she's a full code. And he looks at me and I said, listen, if you're not able to make it happen, I'm going to just call the chief of staff and we're going to make it happen. He goes, okay, no problem. We're going to make it happen because it's life and death now, right? It's now very serious. So I'm calling for a rapid sequence intubation drug kit. We're getting all these drugs ready. We're getting this all done. Now they intubate her. So while we're bagging her, prior to her getting intubated, so now she is going to be intubated. And then she finally gets intubated, which is great, right? Because now we've saved that part. Now, all of that is under control. Two other things. So we have the little extras that we're doing. I'm calling X-ray because I need an X-ray immediately to make sure that tube is right in place. And of course, then X-ray comes over. Gynecology finally comes over. And I said, okay, so we've been contacting you and this is what happened to this patient. So the resident looks at me and he goes, oh God, like he just felt terrible. So I said, so ultimate destination OR? And he goes, yeah. So I said, we're going for an A case. Now, here's the next thing. So now I'm on the phone with the front desk. I said, I need a Bradma, which is like a blue card. It's like a very old school thing. Some places still have it. It's just got basic information. I said, okay. I need you to reprint it. And, all the blood work has been drawn and I get like the porter to take it down immediately. And then I call the front desk to get an extra band or two. My partner, I look at him. I said, you okay? You still with us? And he goes, yep. He goes, yep, I'm still here. And then there's like tons of residents in the room. And I said, okay, all of you have to move out. So now here's the next thing I have to deal with. The family member, the husband, how is he doing? So he's in distress. Okay. So I have to console a 6'3", 200 and something pounder guy off the floor. And I have to get him up off the floor and I have to console him. So I bring him over and I said, okay, so listen, this is what's happening. And she's now going to go to the OR and she'll probably go to ICU afterwards as well. Right. So he was, I had to try to calm him down and I had to move everyone out of the way. And I said, listen, I want him to have a moment with his wife. I said, please have some moments with your wife, kiss your wife, go to your wife, be with her. So I gave him that opportunity because you still have to tend to the family. That's usually what's forgotten. You have to also not forget them as well, So I bring him over, he does that. And I said, my friend, I said, the doctor will speak with you if anything else, but is there anything I can do for you? And he said, no, I really appreciate, thank you so much. And I'm sorry if I snapped at you earlier. I said, don't worry about it. It's all forgiven. Just forget about it. Don't worry. The charge nurse comes over and he pats my back and he's like, oh my God, you took care of something so crazy. And then the time came. So I'm on my phone. The paging phone. And I keep calling the OR. I'm like, you ready yet? Are you scrubbed in yet? Are you scrubbed in yet? They finally scrub in. I tell everyone OR is ready. We got a transporter upstairs. So everyone gets together. They transport her upstairs nicely. So the update on her. So what happened? So it's nice to get updates. We obviously don't get them quite often. But what happened is that ultimately what happened was that the reason why she bled out was because her uterine artery ruptured, and that's why she had the blood in her belly. Yeah. So they had to transfuse an additional 8 units of blood. So I think it was a total of 12 units because she was bleeding out. They resolved all of that, ended up having a hysterectomy, unfortunately, but remember, it's life over limb. You got to save her life. Yep. She ended up in the ICU. But she was okay. And a few days later, they discharged her home. Okay. So, you have some stories that end up being like, whoa, that was, we saved her life and she's, but I did have the ICU fellow the resident that came by later on my shift. So after all that craziness happened, I go back to my own assignment. Right. And, I'm going back to it and everything, and just doing my thing. And then they come by and they actually personally thanked me, and they're like, yeah, so we just want to thank you for being you. And I said, I'm confused. And he shook my hand, and he's like, no, he goes, because if it hadn't been for you, can you imagine what would have happened to her? So
Sure.
sometimes it just takes like an extra set of eyes. Now, what happened to my partner? Was he still with us, or did he faint on the floor? So my partner came up to me, grabbed me, gave me a big hug, and said, oh my God, thank you so much. I said, listen, I will never leave you down. Okay. I'll never leave you hanging. I got you. Okay. I got you. And that was the end of that. So that's a story I can tell you.
Wow, that's an amazing story. So thanks you so much for sharing it. I'm glad it had an eventual happy ending, and that's pretty crazy.
Yeah.
And I mean, that's just one of those things where after having a day like that, then you go home and someone says, so how was your day? Right? It's kind of like, well, let me tell you how it was, and you kind of get through that, or maybe you're the type to say, there's a couple things that happen, but no biggie, right? One of those things. So I guess that gives a bit of a story about, well, you really probably don't know what folks do. So as a nurse, ER, again, glorified on the movies and whatever, but all that sort of stuff, I mean, that could have probably made for a very interesting episode if it was on a show or anything. So yeah, I guess I don't even know how to continue on the conversation after that. But thank you so much for sharing that. And I guess if there's something that you'd want to leave folks with in terms of how or what ER nurses and trauma nurses do, or something to help them out, what is something that you might want to leave the audience with?
It's never a dull day in the ER. It's never a dull day in the ER. Sometimes we get good days where, like, you got the usual, but then, like, I would say that this is always a learning experience and an opportunity. Sure. And like I said, if you don't know and you don't understand, to all the new nurses going out there in field, and even if you're a nursing student right now, but this also applies to any medical professional. So if you're in medical school right now, or, you're in another healthcare profession, an allied healthcare professional that's new to the field, or you're still studying right now, it's never a dull day. Remember to always work in teams. It's very important. And if you have questions, ask them. It's not silly. It's never a stupid question to ask. And always have that intellectual humility. I think I may have mentioned this in a previous podcast before, but having intellectual humility is the most important thing. If you don't know, ask. And these experiences give you a lifetime opportunity to learn. You learn from them and you debrief. So the important thing is also debriefing, like what could have been better, what could we have done better? What could we do differently next time? Is this something maybe we want to carry out in the future? I think with that last example, that would be something we'd want to instate again in the future. But of course, sometimes you just need an extra hand for help. So, and there's nothing wrong with asking for that.
For sure. And all that comes from offering a little bit of help and support to have a nice story to tell at the end. So thanks so much, Eram, for sharing that story. And hopefully we'll have you back for a future episode.
Absolutely. And thank you so much for having me here.
Take care.
Thanks for joining us on the SIWIKE, Stuff I Wish I Knew Earlier, the podcast. If you like the podcast, please subscribe on iTunes, Stitcher, or wherever you found this podcast. And if you can give us a review, that would be very appreciated. Feel free to contact me on LinkedIn at Lukidanu, Lukidanu, and the same on most social media platforms. And I look forward to hearing from you. Thanks. Bye.